Hi, this is Keith. This is a lecture from Chapter 14. This presentation goes along with Chapter 14, so if you haven't read it yet, it's a good idea to do that first and then watch this presentation. Also, remember that the quiz is based on material in the book, so this lecture is a good overview of the chapter, but it is not an adequate replacement for reading the chapter. Okay, let's get started. In this presentation, we'll discuss sexual functioning difficulties, getting into definitions, types, and prevalence. We'll also discuss physical causes of sexual function difficulties and dissatisfaction, psychological causes of sexual function difficulties and dissatisfaction, sexual dysfunction enhancement, and treating sexual dysfunction difficulties. The first thing that should be said is that sex problems are normal and typical. As you'll see throughout this presentation, sexual problems are commonly reported for persons of all genders and cut across racial and ethnic lines and sexual orientation. So if you've experienced them, you're in good company. However, since relatively little research has been done on the sexual functioning difficulties of LGBTQ plus individuals and couples, just keep in mind that most of what we know about sexual dysfunction comes from research with heterosexual couples. Given that having sexual problems is normal, how do we then define sexual problems? The standard medical diagnostic classification comes from the American Psychological Association's DSM-5-TR. For the rest of this presentation, I'll just refer to this as the DSM. This is the classification system for mental health diagnoses that is most frequently used in the US and includes both sexual dysfunction and sexual disorders. These terms tend to imply a strong medical basis for sexual problems and tend to downplay the impact of individual perception on people's sexual difficulties. An alternative way to frame sexual problems is to refer to sexual function dissatisfaction, which is a common outcome of a difficulty in sexual functioning. Sexual function dissatisfaction acknowledges sexual scripts as individuals and can be as individual and can be impacted by emotional, physical, and relational aspects of a sexual experience. So be sure to keep in mind that while we use the APA's DSM to describe sexual problems in our healthcare system, there are other ways to define and conceptualize it. And we'll talk about some of those later in the lecture. So that said, how does the APA's DSM define sexual dysfunction? It defines it as a clinically significant disturbance in a person's ability to respond sexually or to experience sexual pleasure. All of the dysfunctions we'll discuss today require that symptoms be present for at least 6 months, unless caused by a substance or medication use, and it also must cause significant distress. And it further notes that sexual response and function occur as an interaction of biological, sociocultural, and psychological factors. As I noted a bit before, the DSM tends to reflect a psychiatric model that reflects a heterosexual context of relationships. Here you see a list of sexual dysfunctions and disorders according to the DSM. Now, we'll talk in more detail about these disorders later on in the presentation. However, note that these disorders are sometimes more relevant to persons with female anatomy and sometimes more relevant for persons with male anatomy, and in some cases relevant to all persons. So again, feel free to pause here and read through the different definitions of these different dysfunctions and disorders, and we'll talk more about them later. However, as noted before, the classification system presented in the DSM isn't the only one. In recent years, the Working Group for a New View on Women's Sexual Problems has offered a different classification system. Now, that working group did so because it believes that the physiological framework that underpins how the classification system in the DSM works falsely assumes equivalency between men and women and fails to acknowledge the role of relationships and differences among women. So the working group instead describes sexual function problems as discontent or dissatisfaction with any emotional, physical, or relational aspects of sexual experience. in one or more of the following categories. So the first category is socio-cultural, political, or economic factors. So problems in this area could be due to the lack of access to educational materials or the lack of time or energy due to family commitments. The second one is partner and relationship problems. So this refers to incompatibilities in the interests between partners or problems that arise from interpersonal conflict, among other issues. In the realm of psychological problems, those could stem from past abuse in relationships or fears of STIs. And finally, medical factors could result from substance use or STIs or other medical conditions that impact sexual health. Okay, so let's take a look at how prevalent different types of sexual problems are among adults. In the next few slides, I'll present information taken from a large study of adults in Norway published in 2022. Here you see the percentage of sexually active men and women in Norway who reported sexual problems lasting at least 3 months in the past year. On the slide, you see the percentage of adults who reported the lack of sexual interest, the lack of enjoyment in sex, feeling anxious during sex, and having no excitement or arousal during sex. So the first thing to notice is that there appears to be some gender differences between male and female participants, and that sexual difficulties can change by age. For example, women of all ages tend to experience a lack of interest in sex lasting 3 or more months in the past year, more so than men, and this lack of interest tends to peak between the ages of 30 and 44. However, there are other types of sexual problems where there seems to be very little difference between sexes, such as feeling anxious during sex, where the percentages are relatively similar between males and females. So again, feel free to pause and take a look at some of these differences in these areas. Now, on this slide, you see the percentage of sexually active males and females reporting sexual problems lasting 3 or more months in the past year that are different than the slide we just saw before. So at the top, you see the percentage of males and females who reported difficulty in reaching climax, followed by reaching climax more quickly than they would have liked, and trouble getting an erection or keeping an erection in males, or having an uncomfortably dry vagina for females. So you see that females report more trouble reaching climax, while males clearly report reaching climax more quickly than they would like to, at much higher percentages than females. Notice that on the last graph, roughly equal percentages of males and females at different ages report either trouble getting or keeping an erection or experience an uncomfortably dry vagina. Now, from the same Norwegian study, you see here the levels of distress among men and women. There are slight differences by men and women, such as more women reporting mild or severe distress from the lack of sexual interest and the lack of enjoyment in sex, more so than men. But overall, there aren't huge differences in distress levels by experiencing no excitement or arousal during sex and not climaxing or taking too long to orgasm between men and women. But as you can see on this slide, a notably higher percentage of men express moderate or severe distress about reaching a climax too early, more so than women. In contrast, roughly equal percentages of men express distress around erectile difficulties as the percentage of women who express distress over vaginal dryness. And about equal percentages of men and women say that they are moderately or severely distressed by having at least one sexual problem. So overall, you can see across these different slides, there are some differences by sex, but not as many as you might have assumed. Okay, so moving on, I'm now going to present the results of a study that was conducted among US adults that was recorded in 2009 on their experiences during their last sexual episode. So here you see the percentage of self-reported sexual functioning at the most recent sexual event among US adults ages 18 to 59. So males and females were asked to report whether they experienced sexual arousal, pleasure, erection difficulties for males or lubrication difficulties for females, pain during sex, uh, uh, or orgasm during their last sexual experience. So a few things to note here. First, fewer females reported experiencing quite a bit or an extreme amount of arousal or pleasure during their most recent sexual experience than men, as shown on the first two graphs. Moreover, females tend to report slightly higher rates of lubrication difficulty compared to the percentage of men who report erection difficulties at their last sexual experience. That's in the middle graph. In the fourth graph down, you also note that 30% of women report at least some pain during sex, and over a third of women, shown in the last graph, reported that they did not experience an orgasm in their last sexual episode with a partner. So you'll notice that there are some differences when you compare the results here to the Norwegian study, but again, that just may be due to the differences in samples. Now that we know about the prevalence of sexual difficulties and experiences by adults, both in the US and worldwide, let's take a talk about different disorders according to the DSM. The first group of disorders we'll discuss are disorders of sexual desire, which is the number one sexual functioning problem among American couples. More than one half of married couples experience disorders of sexual desire at some point in their marriage. Most often, experiencing low sexual desire is caused by psychological distress that can result from depression, having stressful life events, and having interpersonal and relationship difficulties. The DSM diagnoses for disorders of sexual disorder include female sexual interest arousal disorder, male hypoactive sexual desire, and erectile disorder. So let's go through these. So for female sexual interest arousal disorder, females must report three or more of the following symptoms: the absence or reduction of interest in sexual activity, a reduction in sexual fantasies, a reduction in sexual excitement or pleasure during sexual activity, a decrease in sexual interest or arousal in response to sexual cues, reduced genital or body sensations during sex, and either no or reduced initiation of sexual activities or being receptive to one's partner's initiation of sexual activities. So that's a pretty long list. Experiencing female sexual interest arousal disorder has a strong psychological component. However, it may be impacted by physical problems such as experiencing pain during sex. So it's a really complex issue to unpack. Now, males may experience male hypoactive sexual desire. Hypo means lower. In this case, lower activity or interest in sexual activity. The DSM defines this disorder as both low or absent desire for sexual activity and deficient or absent sex related thoughts or fantasies over 6 or more months that causes significant distress. Again, the fact that it has to cause significant distress is an important part of the diagnosis. This disorder may be associated with erectile or ejaculatory difficulties or caused by strenuous exercise. Finally, with erectile disorders, this is the inability to obtain and maintain an erection for at least 6 or more months. It also must cause significant personal distress. Fear of not being able to achieve an erection is quite high among males, and the prevalence of erectile disorders increases with age, with more than twice as many men aged 50 to 59 reporting these problems than men who are 18 to 29 years of age. That could be due to a host of issues ranging from psychological to medical issues. The next grouping of sexual disorders are referred to as orgasmic disorders. These include female orgasmic disorder, premature or early ejaculation, or delayed ejaculation. In female orgasmic disorder, there is difficulty in experiencing orgasm and/or a markedly reduced intensity of orgasmic sensations in women. These symptoms must occur almost all the time and for a minimum of 6 months. Female orgasm is not universal. In fact, a slight minority of women rarely or never have them. 37% of women in a large study reported not having an orgasm at their last sexual episode, and about 10% of women reported never having experienced an orgasm in their lifetime. Premature or early ejaculation is a recurring and continuing pattern of ejaculation during partnered sexual activity within 1 minute of penetration. The definition of premature ejaculation varies among individuals, populations, and cultures. But if you use the very narrow definition of the DSM that requires that ejaculation occur within 1 minute after penetration, then relatively few people, few males or persons with male anatomy would be diagnosed with this disorder. However, as we saw in the study conducted in Norway, between 11 and 29% of men reported reaching climax before they wanted to. So again, it really depends on how you define this disorder. Finally, delayed ejaculation is the marked delay or inability to ejaculate, which must be experienced on nearly all occasions of sexual activity. Delayed ejaculation can lead to extended sexual intercourse that can be exhausting or cause genital discomfort. It is also important to note that ejaculation is not the same as orgasm. So a male may be able to have an orgasm but not ejaculate. And what complicates this disorder is that there is no consensus as to what is a reasonable time to experience ejaculation. The next group of disorders is referred to as sexual pain disorders. This group of disorders is now called genetic pelvic pain penetration disorders. So this group of disorders is characterized as one of four diagnostic categories: marked difficulty having vaginal intercourse or penetration, marked vaginal or pelvic pain during a vaginal intercourse or penetration attempt, marked fear or anxiety about vaginal or pelvic pain in anticipation of as a result of vaginal penetration, and marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. So, a diagnosis of general pelvic pain penetration disorder is based on persistent and recurrent difficulty with any of the four symptoms I just mentioned, and that these symptoms cause significant interpersonal distress. Okay, let me mention a few other dysfunctions and disorders. Sexual function difficulties that occur with intoxication or use of various drugs are called substance or medication-induced sexual dysfunction. These types of disorders are very common among people taking antidepressants or antipsychotic medication and may occur among people using specific types of illicit substances, such as heroin or ecstasy. Peyronie's disease is a condition in which calcium deposits and tough fibrous tissues develop in the corpora cavernosa within the penis. So this disorder primarily occurs in older men and can interfere with getting an erection and intercourse. And finally, priapism is having a prolonged and painful erection, which occurs when blood is unable to drain from the penis after an erection is achieved. While this is pretty uncommon, priapism may be a serious medical condition if it lasts too long, since tissue can begin to decompensate and lead to a serious medical emergency. Until recently, researchers believed most sexual function difficulties and dissatisfaction were almost exclusively psychological in origin. But more recent research shows that physical and environmental factors can impact sexual function difficulties, including hormones, problems related to the vascular, neurological, and endocrine systems, prescription drugs, and cancer treatments, among other things. So in the next few slides, we'll take a look at both physical and psychological causes of sexual function difficulties and dissatisfaction. Physical causes of sexual function difficulties and dissatisfaction in men include diabetes and alcoholism, which are the leading causes of male erectile difficulties. However, there are other causes that can include lumbar disc disease, multiple sclerosis, atherosclerosis or hardening of the arteries, spinal cord injuries, prostate cancer treatment, drug use, smoking, bicycle-induced sexual difficulties that can restrict circulation and affect heat regulation in the testes, and diseases of the heart and circulatory system. Okay, so what about physical causes of sexual function difficulties and dissatisfaction among women? So these causes have some similarities with those that impact males, but there are a few differences. So causes can include, once again, diabetes and heart disease, but also include hormone deficiencies and neurological disorders, general poor health, fatigue, substance use like drug use and alcoholism, as well as spinal cord injuries or multiple sclerosis, having an obstructed or thickened hymen, clitoral adhesions, infections, scars, a constricted clitoral hood, vulvodynia, or a weak pelvic floor muscle. Also, the use of antihistamines and marijuana, and as well as endometriosis and ovarian and uterine tumors and cysts. Another factor is clitoral irritation and vaginal or urinary tract infections. So, quite a few physical causes, both in males and females. Those are some of the physical causes of sexual function difficulties and dissatisfaction. But what are some of the psychological causes? Some causes are relatively straightforward. Those include feeling fatigue and stress. Feelings of fatigue can come from the demands of a job or raising children, leaving people feeling too tired or exhausted to engage in sex. Stress from worries about finances for illness can also lead to a loss of sexual desire. Now, sometimes these difficulties can arise from um, ineffective sexual behaviors, such as uh, cases where people have a lack of experience about what actually is effective in stimulating their partners. Now, as we talked about, many people experience anxiety around their performance of sexual relationships. In some cases, people experience what we call spectatoring, in which they become a spectator of their own sexual behaviors. So this can be disruptive because people who do this often are critical or judgmental of their performance, and that can really interfere with their sexual enjoyment. Finally, having an excessive need to please a partner can interfere with sexual enjoyment. This can sometimes lead to faking orgasms just to please a partner. Other psychological causes of sexual function difficulties and dissatisfaction may include conflicts within the self. This could be the result of shaming experiences around sex while growing up, leading to the belief that sex is quote unquote dirty. For example, among gay men, lesbian women, and bisexual individuals, they may experience internalized homophobia because of the negative messages about their sexuality that they received from family, friends, or institutions while growing up. And these negative messages could result in self-hatred because of one's homosexuality. So the source of conflict could also arise from experiences of child sexual abuse, adult sexual assault, and rape. And of course, there are also relationship causes. So all couples at some point experience difficulties, and often the challenge is balancing separateness with togetherness to get each partner's needs met while also maintaining the intimacy of the relationship, and that can be really challenging. Now, before we talk about how to treat sexual disorders, it's important to step back and ask ourselves why we should put such an emphasis on it. So, as noted by the World Association of Sexual Health, there is increasing evidence that shows that sexual pleasure is integral to broaden one's sexual health, mental health, sexual health, well-being, and rights, and that it can lead to improvements of health overall. So, good sexual health extends far beyond the bedroom and really impacts all areas of our lives. In the goal to promote a pleasure-based approach to sexual health and sexual rights, the World Association of Sexology developed the Declaration on Sexual Rights. Now, these rights include the things that you see on this list. I'm not going to read all of them, but they include things like the right to the possibility of having pleasurable and safe sexual experiences free of discrimination, coercion, and violence. And that is a fundamental part of sexual health and well-being for all persons, and it also includes the right to sexual pleasure that includes the possibility of diverse sexual experiences. So again, you can read through the rest of these, but kind of, as you do, think through sort of what are the rights that are seem obvious to you, and what are some of the rights that maybe weren't so obvious that are a little bit surprising. So now that we've looked at causes of sexual function difficulties and dissatisfaction and laid the groundwork for the importance of sexual pleasure, what can we do to enhance sexual pleasure or treat sexual difficulties? So let's first focus on sexual enhancement. Sexual function enhancement refers to improving the quality of a sexual relationship. Sexual enhancement may be for people who function well sexually, but who want to improve the quality of their sexual interactions or relationships. The goal of a sexual enhancement program can include things like providing accurate information about sexuality, developing communication skills around sex, fostering a positive attitude about sex and sexuality, completing sexual homework for practicing techniques discussed in therapy, and increasing self-awareness. Okay, let's stay on the topic of developing sexual self-awareness for just a minute. Now, one area for developing self-awareness is knowing when we're having good sex. So we'll know that we're having quote unquote good sex if we feel good about ourselves, our partners, our relationships, and our sexual behaviors. As such, we should feel good before, during, and after being sexual. In order to fully enjoy our sexuality, we need to explore our conditions for good sex. And each individual has their own unique conditions. Someone might have as their condition a need to feel emotionally close with their partner. Someone else may have a condition for spontaneity and mystery. But either way, we should spend some time thinking about our own conditions for good sex and how to express those with our partners. Now, sometimes homework exercises may be given to enhance sexual functioning. One exercise is using a mirror to uncritically examine your genitals. It's important to understand your body. Other homework assignments might be having an evening to relax and explore your body through touch, and that could include masturbation. Another is developing your own erotic sexual voice by journaling about it and discussing it with your partner or maybe even a close friend. And of course, Kegel exercises for everyone to strengthen the pelvic floor and enhance sexual functioning. Finally, discovering and trying out erotic aids or sex toys. There are plenty to choose from, and those can be ordered online. And erotic aids or sex toys can include things like dildos, anal toys, masturbation aids, and other enhancements. A key element in enhancing sexual pleasure is to intensify erotic pleasure. By intensifying erotic pleasure, the focus is less about whether you're performing well, and definitely less on your sexual functioning, and the emphasis is more on your experience of eroticism in that moment. Studies show that developing and maintaining sexual desire is important to a satisfying couple sexual style, and the key appears to be in integrating intimacy and eroticism, or what has been called, quote unquote, building bridges to desire. So, this idea is that it's really hard to juggle demands of life and still find the space to have a sexual relationship. So, one way to foster that is for couples to truly understand what situations might increase their desire. For example, couples could discuss what two favorite ways for each of them to initiate a sexual encounter are, and what are the two favorite ways to be invited into sex. So, through these bridges, we can start to increase our own and our partner's desire. Clearly, increasing sexual arousal is key to a healthy sexual relationship. Sexual arousal has two elements. The first is having your conditions for good sex met. And again, this is knowing your own conditions for good sex. Is this having a private space or maybe sometimes a public venue? That's up to you. The second is having a focus on the sensations you are experiencing. This is allowing yourself to be in the moment. So, with a bit of communication and planning, a decline in sexual passion and satisfaction is not inevitable. Those can be achieved. Here you see the percentage of sexually satisfied men and women versus those who are dissatisfied, who indicated that they had done different sexual activities in the past year to improve their sexual life. So let's focus on males and females who are sexually satisfied to understand what they do to increase their satisfaction. So for satisfied males, at least 50% or more reported the following: that at least one of them gave a mini massage or back rub. One of them wore sexy lingerie. They took a shower or bath together. They planned a date night to be sure that they had sex, or they tried a new sexual position. So again, that was 50% or more of males said those things led to a more satisfied sex. So notice that the top activities among satisfied females are the same ones that males reported, but with a slightly different percentage. So, for example, 71% of females reported that they or their partner wore sexy lingerie compared to 67% of males. So, these are the types of activities that may lead to a more satisfying sexual experience. Take a look at these and see what activities you think would bring more sexual satisfaction to yourself. In addition to the activities that were associated with sexual satisfaction, it also matters how partners communicate with each other. So on this slide, you see the percentage of sexually satisfied men and women compared to those who are dissatisfied that indicate whether they or their partner had talked about sex in the following ways. So for women who are sexually satisfied, 56% said that one of them praised the other. 50% stated that their partner asked for something that they wanted in bed, and 42% said that they themselves asked for something that they wanted in bed. The order of the highest percentages for men was slightly different than for women, but essentially the same three discussions were found to be the most highly sought by males. So there's a lot of agreement between the sexes in terms of what kind of conversations to have. Okay, let's continue this presentation about how to treat sexual function difficulties. Now, Masters and Johnson were pioneers in the cognitive behavioral approach, which suggests that how we think about sex can really impact how we behave. We know from their research and a lot of later studies that a majority of sexual function problems are the result of sexual ignorance, faulty techniques, or relationship problems. For this reason, we treat difficulties using a combination of cognitive and behavioral strategies. Other important features of treatment include a focus on treating the couple rather than just the individual. And that treatment tends to be sensate focused. So by this we mean that the treatment is focused on prioritizing touch and the giving and receiving of pleasure. In other words, the focus is not on achieving orgasm and it is not on penetrative sex. Rather, it is about tuning into touch and the reciprocal giving and receiving of pleasure with your partner. So, what are some of the ways to cope with and manage sexual difficulties, especially if treatments aren't 100% successful? So, we have some options. And again, this is sort of coping with sexual function difficulties in some ways when we tried a few things and they don't tend to be sort of working very well. First, we could explore ways to change the situation, like ending the current relationship or seeking medical solutions. We could also amend our goals, such as prioritizing relational aspects of the partnership rather than sexual aspects, or by having more realistic expectations about the frequency of good sex. Finally, we could live with a gap between our sexual goals and the circumstances. Now, this isn't ideal, obviously, but that gap is likely to change over time and not be static once it's set. Sex therapy utilizes different techniques for treatment of specific problems. Let's take a quick tour of some of these techniques. So, for female orgasmic disorders, partners are encouraged to support the woman to have an orgasm any way it happens for her. In other words, there needs to be a strong communication of needs and desires between the couple. For erection difficulties, it's critical to address fears and anxieties as a way to improve functioning. Obviously, there are also medications such as Viagra that can assist with erectile difficulties. For early ejaculation, the therapy may include an exercise that we call the squeeze technique, where the penis is squeezed prior to ejaculation to interrupt the sensation and prolong sexual activity. Now, over time, the person kind of learns to delay ejaculation to a point that feels satisfying. And for delayed ejaculation, the male may be coached to focus on the sensation rather than trying to make ejaculation happen. Often with delayed ejaculation, the person is sort of in their head, and that can end up being really frustrating. So by focusing on the sensation and not on the finale, the ejaculation may actually happen sooner. Now, especially with erectile and ejaculation difficulties, it may be important to address some common erection myths. These include the following: that an erection is something that is achieved. The reality is that not everyone can achieve an erection, and healthy sexuality can include other experiences like erotic touch or pleasing one's partner. Another type of myth is men are sex machines, always ready to go and always hard. While it may feel cool to act as though this is the case, men also need the right set of circumstances to feel sexual. Another one is during a sexual encounter, you get only one shot at an erection. That's just not the case. Sexual arousal can ebb and flow throughout the encounter, so you just sort of have to enjoy that ride. Another one is, ugh, I blew it last time. I will never get it up again. And this is almost always not true. This might be true if there's a medical issue going on, but the reality is that there are many opportunities to have an erection, and just because it doesn't happen one time doesn't mean it won't happen in the future. One type of sexual therapy was developed by Helen Singer Kaplan, who modified Master and Johnson's behavioral treatment program for sexual difficulties to include psychosexual therapy. Now, this is the type of cognitive behavioral therapy that works well for arousal and orgasmic difficulties that are the result of mild to moderate sexual anxiety. Other non-medical approaches attempt to work around the expense and time and money of cognitive behavioral and psychosexual therapies. So these are sometimes what we refer to as brief approaches to sexual difficulties. These include the PLISSIT model of therapy, which stands for permission, limited information, specific suggestions, and intensive. So again, this is a type of brief intervention where we can sort of have a powerful impact in a brief period of time. So the first step is to give permission to the client to be sexually active, be sexually seek sexual pleasure, given all the norms and taboos around sex. Some clients simply need permission to be sexual. Next, the therapist will provide information about that specific sexual difficulty. So it's a bit of psychoeducation. The third step is the therapist provides specific suggestions about how to address the sexual difficulty. So this gets into some of the methods we talked about for specific sexual difficulties, like the squeeze technique when trying to treat premature ejaculation. So if these three steps don't work, then a more intensive therapy is then recommended. So again, the idea is let's provide a brief intervention in the first three steps, and if those don't work, then a more intensive intervention might be recommended. A third type of treatment might be self-help or group therapy. For example, there are groups that address issues like compulsive sexual behavior that help clients feel less isolated and also provides support for change. Because sexual function difficulties are often a combination of physical and psychological problems, there are medical approaches as well. These include lubricating jelly or estrogen therapy for vaginal pain, testosterone therapy for loss of sex drive and function, low energy and strength, depressed mood, and low self-esteem, microsurgery to improve blood flow problems, using medications like Viagra and Cialis for erection difficulties, using medications like Addyi to boost women's sexual desire. Homeopathic products are also available, but you have to be really careful about these kinds of products since they are not regulated by the FDA and can make certain claims that are not supported by sound science. Finally, when treatment fails, individuals may find ways to cope with and adjust to these difficulties, and we discussed some of those in the previous slides. Okay, to end with today, just to keep in mind that for LGBTQ plus individuals, sexual issues might differ from those of heterosexual individuals and couples. Importantly, the context in which issues arise may differ significantly between heterosexual and LGBTQ plus persons. For example, rather than focusing on penile vaginal intercourse, gay men may be focused more on anal intercourse, or queer clients may be focused on the use of sexual aids. So behaviors rather than intercourse are the sort of focus of treatment. Assumptions about what behaviors will be important should be challenged, and it's important to ask LGBTQ plus clients what behaviors are most important to them. In addition, homophobia, both societal and internal, may be an issue for some clients. Again, don't assume that this will always be the case, but it's important to understand what, if any, role stigma may be playing in their sexual difficulties. Okay, and that is the end of this lecture.